Thank you so much. A very good afternoon to all of you. At the outset, thank you to Dr. Mohan, Dr. Anjana, Dr. Ranjit, even Ranjani for having me here today. And it's an honor that you are chairing my session. I have both ma'am and Ranjani, you both aspire and your commitment is really credible in this field. I would be talking about medical nutrition therapy in diabetes. We have heard in all halls about nutrition and the importance of nutrition when we are treating diabetes mellitus. In the morning, Dr. Anjana did share so beautifully the DIAB study, which showed different components of probably I would say a lag that is there. And when we know that there is a lag in certain parameters, certain nutrients, why are we not being able to address it? So I would be talking about the guidelines that are available, and maybe by the end of the session we will know what to do to address those lags. There are no disclosures. It is in accordance to the continuing criteria of being evidence-based and non-promotional. So probably the lag is because diabetes is not just one entity, it is a group of metabolic disorders. And herein, when I'm talking about the nutritional aspect, comes the altered carbohydrate metabolism. That could be characterized by hyperglycemia, that could be because of defects in the insulin secretion or action or both. And when we classify diabetes mellitus, definitely diabetes mellitus type 1, type 2 and gestational play the most important role. And then we also heard about different types of diabetes mellitus. When we talk about medical nutrition therapy, I would say that it is not only a very integral component of diabetes management, but also a very integral component of self-management and education. Why? Because we know through various studies that MNT is effective when we want to maintain glycemia, and this is both for type 1 and type 2 diabetes. Also, it helps us because it is evidence-based, and it would help the patient make healthful choices that can be sustained for long. So MNT definitely includes the screening and assessment, patient history, food nutrition history, also what medication or therapeutics the patient is on. The screening tools are widely available, also the social and the psychological history. So medical nutrition therapy should be healthy eating with nutrient-dense foods that are easy to access by the patient. The patient is willing to make those changes, as well as you provide practical tools to keep the pleasure of eating at its optimum, because these conditions, diabetes is not a standalone where it is 1 year, 2 year, unless we are talking remission, that also doesn't come in so easily. So we are talking about effect for a long period of time, and it should support improving the HbA1cs, the cardiovascular markers, as well as help to maintain the ideal body weight and prevent or delay the complications. So we have come a long way in our understanding, right from where in the initial phases it was innate carbohydrate restriction to now definitely we are talking about individualized carbohydrate countings as well as the glycemic index. If we look at the dietary patterns worldwide, if we look at fruits, if we look at milk, if we look at whole grains, if we look at omega-3, when it comes to our part of the world, we do not even meet half the required optimal allowance that is there. But when it comes to sodium, when it comes to saturated fatty acids, we are the forerunners somewhere, right? So the MNT should start addressing these issues also, because the whole goal of MNT is to prevent the complications. If we look at gene mutations and the diet interactions, if we look at the nutrients, we know that we dwell with low protein, we dwell with not only macronutrient deficiencies, but micronutrient deficiencies also. So various meal plans are available that support insulin sensitivity, that help to prevent cardiovascular markers, right from Mediterranean diet to plant-based diet to even the realm of the whole umbrella of time-restricted eating. But somewhere, even though there are enough studies that show that these not only help glycemia but also help to prevent cardiovascular markers, the adherence somewhere is an issue in the long term. So what are the medical nutrition therapy recommendations? Right from nutrition prescription to energy intake to fiber to glycemic intake to the nutrient adequacy as well as physical activity. I will try to run through all this very quickly. So first, I would say for a BMI of more than 25, and in Dr. Anjana's lecture, we did understand what is a metabolically active obesity. Right? So in those cases, a goal is at least 5% of weight loss to prevent, or in the pre-diabetic stage, it could be 7 to 10% depending on what the goals are. And a variety of balanced meal plan can be prescribed. So consensus guidelines around energy intake are that it should be adequate to maintain the ideal weight as well as health in adults. And when you're looking at children, it should be enough to support the growth too. And the energy requirements generally around 30 kilocalories per kg body weight. Macronutrients, the carbohydrate intake could be around 50 to 60% of the total calorie intake, where complex carbohydrates need to be primed, and definitely low glycemic carbohydrates are a good tool that support the whole process. But important is not just what quantity and quality, but it is also the carb management strategies. So monitoring the carbohydrate intake, hand-holding the patient could work a long way, and especially when we are working with diabetes mellitus type 1 patients, where you need to take in consideration the available insulin as well as the carbohydrates that you are providing. And the tools could be here carbohydrate counting or plate method or food choices and carbohydrate choices. Also, this will not only help prevent hyperglycemia, but here we are in type 1, even wanting support to prevent the complication, which is acute complication, hypoglycemia. The effectiveness of carbohydrate counting on A1Cs in type 1 DM, many studies are there around it. Here I have stated for a study by Professor Fu, who studied subjects of 773 subjects over a period of 3 months, and the primary outcomes were definitely HbA1c reduction. But what I would like to say is also look at the study by Professor Bayram, where it is not just the reduction in HbA1c, but also the reduction in the overall BMI or even the betterment of the lipid profile. When we talk about glycemic index, yes, definitely it is an excellent tool, and very easily the entire list of what low glycemic index foods are, even in the Indian context, is available. Here I would like to state that don't look at glycemic index or just whole carbohydrates as is, but carbohydrate profiling, glycemic indices also play an important role. Ma'am has done a lot of work around millets, and we have seen that even certain millets would have high glycemic. So when I'm talking from a context that when we are asking patients to have a part of their whole carbohydrate allowance through whole grains, the glycemic index and the choice of the whole grain also is pertinent. Fiber intake, we know researchers do show that soluble fibers have a very important role around not only diabetes but also in obesity, also in managing the cardiovascular markers. So it would be around 14 grams of fiber per 1000 cal per day. Protein, lot has been spoken and lot can be spoken. So amino acids such as glycine, leucine, they do stimulate the insulin release and do support the muscle growth. The protein recommendations by RSSDI, ADA, in adults, it is around 0.8 to 0.9 grams of protein per kg per day. And if we look at patients who are diabetic but not on dialysis, right? No significant study has shown that going below 0.8 has had a great impact. Rather, you are pushing this patient to a risk of malnutrition. Also, the role of protein in weight management, because here you want to improve the insulin sensitivity. So this study by Professor Mathis, they had two set of patients. One they provided 0.8 and one they provided 1.2. And definitely patients on 1.2 had better fat-free mass restoration. This was a small study conducted in our center. The context here being that if the patient is with cancer and that patient walks in, somewhere we trigger malnutrition at the first go. But when a diabetic patient walks in, yes, definitely we want to preserve the lean body mass, but our first aim and goal is to attain glycemia, right? And in that, maybe when we are adjusting the insulin doses or the medication, we may not be priming the protein at the go one. Fat recommendations, definitely saturated fatty acids less than 7% of the total energy, and the MUFAs could provide 10 to 15% of the total energy. The saturated fat acid reduction comes from the context that abnormal lipid metabolism not only is a core at insulin resistance, but also for diabetes. Many patients walk in and then they say that why you want us to not eat or reduce fat, and we are having home cooked meals only. But in India, different cultural cuisines, different way of cooking, different oils and that are used in cooking, the saturated fatty acid content may even be high in a home cooked meal. And definitely we are reeling under the YY paradox, where for a static BMI of equivalent BMI, definitely the fat percent that we carry is more. Could be because of lack of physical exercise, could be because of genetics. Visceral obesity and dysfunctional adipose tissue then is something that we need to address, because we are now addressing the concept of metabolic inflammation even in diabetes. So more the fat tissue, more the inflammation, more is the insulin resistance. So we know that both the adipocytes as well as the endothelial cells, the adipocyte hypertrophy is seen when the fat mass increases. This could lead to hyperlipidemia, this could lead to metabolic dysfunction, this could lead to inflammatory markers being more. And the adipose tissue-based chronic disease concept, where it would increase the inflammatory markers such as TNF-alpha, reduce the adenopectin. That could in fact reduce energy expenditure and increase eventually the insulin resistance. A lot of studies now around hypoxia-induced factor 2, where it reduces inflammation and exosomes does increase the macrophages. But what I want to say is that when you are addressing specifically diabetes mellitus type 2, we see more so obese patients, and adjusting the calories and increasing the protein could be a way forward. Also, high fat, high glucose, typically based diets could then affect the gut microbiota, where increased firmicutes and decreased bactericides could again lead to inflammation, and this is chronic inflammation that I am talking of. Lot of studies around Akkermansia for specifically in weight management and diet-induced obesity. So also when we are talking of gut, lot of role of probiotics and type 2 has been lot of studies around it. I took this up because now we see a lot of marketing around probiotics, okay? Just hang on here because I want to address something here. If we talk about gut health, we have, wherever we are from, lot of cultural foods around gut health, right in the east, the panta bhat, to the curd, to ambil, to even kinema and gundruk. Inclusion of the cultural foods itself could support gut health, because when we are talking about gut, it is not just the probiotics that you provide is going to help, but what is the macronutrient composition of your food, what is the micronutrient composition of the food, how much is the fiber, what are the omega-3 fatty acids that you are providing. That would eventually help the insulin sensitivity. So just by providing probiotics, because the patients themselves come saying that I have been on an XYZ probiotic because of my gut. So it is not that you are just, the supplementation is going to help. It is your macro and the micronutrient composition of food that will eventually help the patient. Ma'am did mention about functional foods, just a small slide around it, that yes, a lot of researches are now available around a lot of functional foods, and in the era of GLP-1, somewhere even micronutrients such as vitamin D, so to prime the vitamin D, not allow the deficiency to happen, even researches around berberine metabolites that stimulate the GLP-1. So this could also be a supplementation to the therapeutics that the patient is taking. So remember, dietary adherence to the nutritional plan is more important than just any macronutrient pattern, right? The guidelines are available. ADA has done a lot of work. RSSDI has done a lot of work. Other organizations are doing that work. But supporting the patient and providing foods in a way that the patient adheres to it will help glycemia. So individual influences on food choices are important when you are meal planning. Now, I would like to also state that food or nutrients or diet by itself will also not work. So nutrition and other lifestyle factors are important when we are wanting to influence specifically the muscle physiology. This is the dynamic Packing-Co model, where meal timing, the type of nutrient, what was the gut microbiota manipulation that you did at that particular point in time, whether this patient was active, eventually helped to maintain the muscle mass. So it was not just providing, maybe even 1.2 grams of protein that eventually helped. A lot of studies, these are my final slides, but I would want to end saying that sedentary lifestyle is not helping. If you have to help your glycemia, along with nutritional and the therapeutic management, exercise is pertinent. The bed rest study by Ostergaard does show that oxidative stress and inflammation is primed in patients who are not active. So physical activity is important. You cannot afford a muscle atrophy. So at least 150 minutes of physical activity per week. And if a very sedentary patient walks in, sometimes we say just walk 10 minutes after your breakfast, lunch and dinner. You still have started motivating the patient to reach a 30-minute of activity. So behavioral interventions are important. Promoting culturally appropriate exercise that is fun and sustainable too is also very important. If somebody doesn't like it, they are not going to sustain their exercise. And here I would like to applaud Ranjani and Dr. Anjana that they have done a beautiful work around this Tandav. And I think dance is very, very easy and very, very imbibed and can go a long way. This is specifically the high intensity short interval dance exercise. Lot of trials forever have shown that lifestyle intervention is important along with the dietary interventions. If you look at, say, for example, the DPP does show that it reduces the risk of developing diabetes mellitus. So to end, the nutrition prescription, it is a part of your algorithm of care. It is not something that you need to push. And the ADA does suggest that specifically in government setups, when so many patient to the dietitian ratios may be a compromise, MNT should be referred at least at diagnosis or when experiencing a change in the therapy, or even when there is a new health condition that is affecting the nutritional status. So to summarize, the nutritional interventions should emphasize on minimally processed, nutrient-dense foods with portion sizes that manage the insulin to carb ratios, and to provide day-to-day tool and behavioral change so that we can maintain glycemia and health for a long period of time. And diabetes is intergenerational, so one needs to start being active. Dr. Anjana did speak about policy that could help, and yes, if we catch them young, maybe policies around school, policies around parks, I don't know, some way where we can get probably the infrastructure or the motivation right where you can just dance in your house could lead to better health in the long run. Thank you.
The session is now open for...
We're only talking about protein and this, so let's have that active applause for her, please. So we break our sedentary time.